Pathology for Physical Therapy Assistant, Chapter 4, The Immune System, Part 2, page 90. Secondary immunodeficiency. Secondary immunodeficiency disorders such as leukemia, Hodgkin's disease, follow and result from an early disease or event. Defects in the immune diseases occur in viral infections, other infections, malnutrition, alcoholism, aging, autoimmune disease, diabetes mellitus, cancer, chronic disease, steroid therapy, cancer, chemotherapy, and radiation. More specific causes such as AIDS also contribute to secondary immunodeficiency. Iatrogenic immunodeficiency. Iatrogenic immunodeficiency refers to an immunodeficiency caused by a physician, such as occurs with immunosuppressive drugs, radiation therapy, or splenectomy. Immunosuppressive drugs include cytotoxic drugs, corticosteroids, cyclosporin, and anti-lymphocyte serum, and anti-lymphocyte globulin. Cytotoxic drugs kill cells while they are replicating, but because more cytotoxic drugs are not selective, all rapidly dividing cells are affected. Not only lymphocytes and phagocytes eliminated, but these drugs also interfere with lymphocyte synthesis. Other effects of this non-selective selectivity of cytotoxic drugs may include bone marrow suppression with neutropenia, anemia, cytopenia, gonadal suppression with sterility, alopecia, hemorrhagic cytitis, and vomiting, nausea, and stomatitis. The risk of lymphoproliferative malignancy is also increased. Corticosteroids are used to treat immune-mediated disorders. Because of their potent anti-inflammatory and immunosuppressive effects, corticosteroids stabilize the vascular membrane, blocking tissue infiltration by neutrophils and monocytes, thus inhibiting inflammation. They also kidnap T cells in the bone marrow, causing lymphedema. Cyclosporin, immunosuppressive drug, selectively suppresses the proliferation and development of helper T cells, resulting in depressed cell-mediated immunity. This drug is used primarily to prevent rejection of organ transplants, but is also being investigated for use in several other disorders. Radiation therapy is cytotoxic to most lymphocytes, inducing profound lymphopenia, which results in immunosuppression. Irradiation of all major lymph nodes areas are produced, known as total nodal irradiation. Is used to treat disorders such as Hodgkin's lymphoma. It is being investigated for its effectiveness in severe rheumatoid arthritis and lupus nephritis and the prevention of kidney transplant rejection. Splenectomy increases a person's susceptibility to infection, especially with pyogenic bacteria such as S. pneumoniae. Consequences of immunodeficiency. People who are immunocompromised from any of the immunodeficiency disorders are at increased risk for developing infection because their impaired immune system does not provide adequate protection against invading microorganisms. Normal mechanical defense mechanisms may be affected. Respiratory GI systems. Body flora that are normally harmless, such as Candida, may become pathogenic and a source of infection. Additional risk factors for people who are already immunocompromised include poor physiologic and psychologic health status, old age, coexistence of other diseases or conditions, invasive procedures, surgeries, invasive lines, and treatments, chemotherapy, radiation therapy, bone marrow transplantation. The weakened immune system can cause a person to become susceptible to common everyday infectious agents such as influenza viruses. Special implications for the PTA, infection control, and immunodeficiency disorders. Although infection control strategies such as hand washing, standard precaution, and disinfection are important for all people treated in the healthcare system, they are especially critical for individuals whose immune system are altered by primary immunodeficiency disorders, secondary immunodeficiency disorders, and HIV infection. It is important that healthcare providers stop to think about altered defense mechanisms, infectious agents, reservoirs, modes of transportation, infection control strategies to prevent infection in population. Figure 4.4. Pulmonary complications are common among the immunocompromised, accompanied by poor cough reflexes and inability to cough effectively, and susceptibility to pulmonary and other opportunistic infections. In addition, these individuals are often debilitated and easily fatigued. Frequent mobilization and body positioning enhance gas exchange and promote comfort while maintaining strength. Page 91, Human Immunodeficiency Virus. Overview. HIV is an infection of the immune system. If untreated, it results in progressive and ultimately profound immune suppression. AIDS was first recognized in homosexual men in 1981. The earliest sample of HIV-infected blood dates back to 1959, but computer analysis suggests an emergence date of 1930. AIDS is characterized by progressive destruction of cell-mediated T-cell immunity and changes in humoral immunity, even elements of autoimmunity. The resultant immunodeficiency leaves the affected person susceptible to opportunist infections, including unusual cancers, tuberculosis, TB, and other abnormalities that characterize this syndrome. For example, HIV-positive individuals are nearly 2.5 times more likely than HIV-negative persons to have a reoccurrence of TB, and 8 to 10 times more likely to develop Hodgkin's disease compared with the general population. In addition, 25 to 40% of Americans with HIV are believed to be infected with the hepatitis C virus, HCV, primarily among injection drug users, IDUs, and those with hemophilia as a result of blood product used to treat the hemophilia. Mortality rates are higher and life expectancy is lower in people with hemophilia who are HIV positive. Definition. The term HIV infection includes the entire spectrum of illness from the initial diagnosis to full-blown expression of AIDS. 3 distinct points identify this continuum. 1. Asymptomatic HIV, seropositive. 2. Early symptomatic HIV. And 3. HIV advanced disease, AIDS. Not everyone who is exposed to HIV becomes infected, and not everyone who is infected develops AIDS. The explanation for this phenomenon remains unknown, but researchers have shown that infection with HIV and progression to AIDS are controlled by both host genetic factors and viral factors. Incidence and prevalence. Since the first AIDS cases were reported in the United States in 1981, the number of cases and deaths among people with AIDS increased rapidly during the 1980s, followed by substantial declines in new cases and deaths in the late 1990s. New infections in the United States have declined to an estimated 40,000 per year, down from the peak of 150,000 per year in the mid-1980s. The number of people living with AIDS in the United States is the highest ever reported, at more than 1 million deaths from AIDS, declined 63% from approximately 52,000 to 19,000 in the late 1990s. In the United States, the greatest impact of the epidemic is among the IUDs, sex workers, and men who have sex with men, with an 8% increase in this last group. and among racial and ethnic minorities. Increases have been observed in the number of cases attributed to heterosexual transmission among minority women and women older than 50 years of age. The total number of people living with AIDS has increased as deaths have declined. Figure 4.5. Most people diagnosed with AIDS in the United States are aged 20 to 49 years. However, the number of adolescents with HIV in the United States doubles every year. Teens account for 1/4 of the cases of new STDs reported each year, and AIDS in older adults account for 11% of all AIDS cases. Etiologic factors, transmission, and risk factors. The primary cause of AIDS in the type 1 retrovirus, HIV, transmission of HIV occurs by exchange of body fluids, notable blood and semen, and is associated with high-risk behaviors. High-risk behaviors include unprotected anal and oral sex, having 6 or more sexual partners in the past year, sexual activity with someone known to carry HIV, exchanging sex for money or drugs, or injecting drugs. HIV is not transmitted by fomites, coffee cups, drinking fountains, or telephone receivers, or casual household or social contact. As mentioned, injection drug use also continues to play a key role in HIV epidemic. In some large drug-using communities, HIV seroincidence and seroprevalence among baby's awake. This decline has been attributed to several factors, including decreased use of sterile injection equipment, declines in needle sharing, shifts from injection to non-injection methods of using drugs, and cessation of drug use. Ethnicity is not directly related to increased AIDS risk, but is associated with other detriments of health status, such as poverty, illegal drug use, access to health care, and living in community with high prevalence of AIDS. Adolescents are one of the groups at greatest risk for HIV infection, particularly minority inner-city youth. Runaway and homeless youth are especially likely to engage in high-risk sexual activity. The use of amphetamines, ecstasy, and amnitrate is associated with increased frequency of unprotected anal sex, especially among homosexual and bisexual individuals younger than 23 years of age. Page 92. Pathogenesis. The rapid convergence of information from diverse areas of AIDS research makes it impossible to present the most up-to-date information. Scientists are reporting new discoveries daily about the pathogenesis of HIV disease. The natural history of AIDS begins with infection by HIV retrovirus detectable only by laboratory tests. This retrovirus predominantly infects human T4 helper lymphocytes, also known as CD4 cells. The major regulators of the immune response and destroys or inactivates them. Macrophages and B cells are also infected. Replication of the virus can cause cell death. Although the person remains asymptomatic, seroconversion, becoming positive for HIV, usually takes place during the first 3 to 6 weeks of this replication process, but can take longer. After a few months, very little virus is found in the blood. Only HIV antibodies remain in the serum. During the asymptomatic period, also called the early stage, the virus migrates from the serum into the tissue to infect CD4 cells in lymph tissue. The virus continues to kill the CD4 cells in the lymph nodes. Once all the cells are depleted, the virus again enters the blood to infect any remaining lymphocytes, and clinically apparent disease occurs. By the time this happens, the immune system has been compromised and is infected and unable to mount a specific immune response. The immune system dysfunction is even more exaggerated if the host has become further immunocompromised by opportunist diseases. The decline in CD4 cells results in progressive loss of immune system function and the development of a wide variety of clinical signs and symptoms. Table 4.1. This describes the middle stage of symptomatic phase of AIDS. HIV has an extremely high mutation rate even within a single individual, producing competing strains of the same virus that fight for survival against the weapons produced by the immune system. Researchers are studying how different strains of HIV use cell surface molecules in addition to the CD4 molecule to bind to and enter target cells. Clinical manifestations. HIV infections manifest itself in many different ways, see Table 4.1, and differs between adult and pediatric population. Great variations exist among individuals as to the amount of time that passes between acute HIV infections and the appearance of symptoms that the diagnosis of AIDS and death. Asymptomatic stage, CD4 count of 500 cells, MM3 or more. During the early stage, the person demonstrates laboratory evidence of seroconversion, positive for HIV. Highlight that. But remains asymptomatic. Some individuals develop an acute self-limiting infection, mononucleosis-like illness, or substance viral-like syndrome followed by a period of clinical tendency that may last a decade or more. During the asymptomatic period, the infected person is clinically healthy and capable of normal daily activities, normal work habits, and unrestricted level of duration of exercise. Fatigue and general lymphadenopathy with swollen firm lymph glands may be reported during this stage. Early symptomatic stage, CD4 count of 200 to 500 cells. As the infection progresses and the immune system becomes increasingly more compromised, a variety of symptoms may develop, including persistent generalized adenopathy. Nonspecific symptoms such as diarrhea, weight loss, fatigue, night sweats and fever, neurologic symptoms resulting from HIV, encephalopathy, or an opportunist infection. More than half the adults with HIV in this stage report fatigue that limit physical recreational activity. Half the adults who report fatigue are unable to attend school or work. HIV advanced disease, AIDS, CD4 count of 200 cells or less. The neurologic manifestation of more advanced HIV disease are numerous and can involve the central nervous system CNS, the peripheral nervous system PNS, and the autonomic nervous system ANS. The CNS appears to be more commonly attacked by HIV than the PNS. HIV or AIDS encephalopathy, also referred to as HIV-associated dementia, HAD, formerly called AIDS dementia, complex is a primary infection of the brain by HIV. Symptoms can vary and are listed in Table 4.1. In most advanced stages of a disease, severe dementia, mutism, incontinence, paraplegia may occur. A detailed summary of nervous system disorders associated with HIV, including treatment, is available. Dermatologic conditions are common and can be extensive, including malignancies, bacterial, viral, fungal infections, figure 4.6, and reaction to drug treatment. Cutaneous manifestations of HIV can include dry, flaking skin, telangiectasis, and thinning of skin and hair. The prevalence of a condition such as seborrheic dermatitis, psoriasis, Reiter syndrome, acquired ichthyosis, kaposis, sarcoma, scabies is on the rise. Kaposi, sarcoma, purple nodule skin lesions, predominantly affect homosexual men. HIV-associated nutritional disorders may also contribute to nail and hair changes. HIV-associated wounds may occur as a result of Kaposis, sarcoma, herpes, simplex virus, syphilis, injection, drug use, candida, and fungal infections. Post-operative infections and herpes zoster. Pain syndromes. Pain syndromes seen in HIV-infected individuals are divided into three groups: pain directly related to HIV infection or immunosuppression, pain caused by HIV, diagnostic procedures and treatment, and pain unrelated to AIDS or its treatment. Painful sensory peripheral neuropathy is the most commonly reported pain syndrome, followed by pain associated by extensive Kaposi sarcoma and other dermatological conditions. Headaches, abdominal pain, chest pains, erythroglias, myalgias, I don't know. Women infected with HIV experiencing pain more often with greater intensity than men. Women also have unique gynecological syndromes related to opportunistic infections and cancers of the pelvis and genitourinary tract. Peripheral neuropathy, disease or drug-induced myopathy, and musculoskeletal pain syndrome occurs most often in the advanced stages of HIV disease, but can occur at any stage of HIV infection and may be the presenting manifestation. Peripheral neuropathies affect a large portion of people with AIDS and are usually distal, symmetric, predominantly sensory, but other parts of the body may be affected, such as the face or trunk. Peripheral neuropathies generally manifest in a shocking glove distribution, with the feet and the legs most commonly affected. Involvement of the upper extremities is less common and often occurs much later in the disease process. AIDS is associated with neuromuscular skeletal disease such as osteomyelitis, bacterial myositis, and infectious reactive arthritis, osteonecrosis, osteopenia, osteoporosis are increasingly observed in clients with HIV disease. Avascular necrosis, osteonecrosis of the femoral head has been reported. Musculoskeletal pain are associated with wasting process in AIDS, referred to as HIV wasting syndrome. HIV wasting is characterized by a disproportionate loss of metabolically active tissues, specifically body cell mass. These conditions occur secondary to low food intake, altered metabolism, and poor nutrition absorption, with manifestations such as extreme weight loss, chronic diarrhea, unexplained weakness, fever, and malnutrition. Rheumatologic manifestations are transient or substable and appear more often as HIV disease progresses. The arthritis can be severe and does not necessarily respond to conventional medication. Poliomyositis involves bilaterally symmetric proximal muscle weakness and arthritis, may precede or accompany seroconversion. HIV-associated myopathy manifests as a progressive painless weakness in the proximal limb muscles. The weakness is symmetric and often involves the muscles of the face and neck. This type of myopathy may occur in individuals with HIV at every stage of illness. Lipodystrophy or lipodystrophic syndrome, LDS, a syndrome of defective fat metabolism, dyslipidemia, and insulin resistance manifests as central fat accumulation. With visceral fat deposition documented by computed tomographic scans. Alani, shh, shh, shh. Shh, shh, shh. Okay. It is a common problem that occurs soon after starting highly active I don't know. Antiretroviral therapy, HAART. What is it, baby? Okay. Loss of fat occurs in the arms, legs, or face with concomitant fat deposits in the abdomen, breast, men and women, and back of the neck. AIDS-related lymphomas, ARLs, excuse me, including Burkitt's lymphoma, non-Hodgkin's lymphoma, Hodgkin's lymphoma, and other more common types. Primary effusion lymphoma are more likely to occur in HIV-infected people than in the general population. ARLs are now the second most common cancer associated with HIV, are after Kaposi sarcoma and increase with time after infection. The incidence of non-Hodgkin's lymphoma appeared to be declining with the use of HAART, whereas the incidence of Hodgkin's lymphoma may actually have increased in the HIV-infected population. Cardiopulmonary disease continued to be an important cause of illness and death in people with HIV infections, bacterial pneumonia, bronchitis, TB, pulmonary, extrapulmonary, and cytomegalovirus (CMV) infection are common. Opportunistic diseases in the HIV population. Emphysema, asthma, and pulmonary hypertension are also observed in this population. Cardiac involvement, heart and blood vessels, occur as a result of the combination of the HIV infection, medical management, and secondary opportunist infection. Cardiovascular diseases have become a major cause of mortality among HIV-infected people who respond well to antiviral therapy. Myocardial infarction, cardiomyopathy, pericardial effusion, and pericarditis are some other cardiovascular conditions that occur as a result of HIV or its treatment. There is an increasing evidence to suggest that cardiovascular disease appears early and more often among HIV-infected adults than in the general population. All right, medical management, prevention. HIV prevention in the United States has placed the primary focus on persons who are not HIV infected to help them avoid becoming infected. Reducing sexual and drug-using risk behavior has been the main emphasis of public health prevention programs. The overarching HIV prevention goals of the Center of Disease Control and Prevention, CDC, are to reduce the number of new HIV infections and to eliminate racial and ethnic disparities by promoting HIV counseling, testing, and referral, and by encouraging HIV prevention among persons living with HIV and those at high risk for contracting the virus. However, further education of HIV transmission will require new strategies, including increased emphasis on appropriate routine screening, identification of new cases, partner notification, increased stability of sustained treatment, and prevention services for those infected. The addition of a simple rapid HIV test may help overcome some of the traditional barriers to early diagnosis and treatment of infected person. The CDC also recommends routine HIV testings of all pregnant women and routine screening of an infant whose mother was not screened. Diagnosis. Early diagnosis is important so that the early and preventative therapies may be initiated and sex partners can be notified of their risk of HIV and the subsequent need for HIV testing. To establish uniformity in reporting AIDS cases, the CDC has established diagnostic criteria for confirmation of AIDS. The most commonly performed screening test in the is the HIV-1 antibody enzyme immunoassay test, an antibody test to indicate HIV infection indirectly by revealing HIV antibodies indicating exposure to the virus. However, the antibody testing is not always reliable because the body takes a variable amount of time to produce a detectable level of antibodies. Consequently, a person with HIV could test negative for HIV antibodies. Antibody tests are also unreliable in neonates because transferred maternal antibodies persist for 6 to 10 months. The Western blot test is a more expensive test that may be used when there is a concern about false positive results. Treatment. No cure has been found for AIDS, but advances in treatment have successfully transferred AIDS into a manageable chronic condition. The National HIV Vaccine Trials Network has been established to develop the test and test possible vaccine compounds, but an effective vaccine is not imminent until a vaccine is available. The goals of intervention are to stop HIV from replicating, increase the number of CD4 cells, and delay HIV disease progression. Current efforts are focused on 1. Simplifying the drug regimens to improve adherence, once daily dosing. 2. Developing alternatives for those in whom the current medications have failed. 3. Preventing viral rebound, return of high levels of the virus when drugs are discontinued. And 4. Managing the wide range of pharmacologic side effects. Development of drug resistance is inevitable consequence of incomplete suppression of virus plasma cells in individuals with HIV treated with HAART. Non-compliance with the drug regimen, which involves taking multiple drugs throughout the day, can lead to mutation of the virus and resistance of treatment. Drug resistance is one of the most significant threats to effective therapy. Potential toxicities from drug treatment include metabolic disorders, LDS, avascular necrosis of the femoral head, and lactic acidosis. There is no known treatment to stop treatment-induced osteonecrosis. Palliative treatment may include non-steroidal anti-inflammatory drugs, NSAIDs, and pain medication. Surgical procedures to improve blood flow to the affected area of the joint replaced to improve function may be considered when present. Dyslipidemia may be associated with accelerated atherosclerosis and insulin resistance, contributing to increased cardiovascular morbidity and mortality rates in the population with HIV. Non-pharmacologic interventions include nutritional therapy, exercise, mental health support, and alternative or complementary interventions. AIDS-associated weight loss, nutrition deficiencies, loss of muscle mass, wasting syndrome, and other effects contribute to immune dysfunction, faster disease progression in some people, and a variety of complications that can be ameliorated with proper nutrition. The use of alternative and complementary intervention techniques remain an area of controversy and investigation. Page 96. AIDS has changed from an acute to a subacute chronic illness. The development of a combination therapies is extending the lives of AIDS clients, keeping many healthy enough to avoid hospitalization and or return to their baseline after illness, extending survival and even resulting in return to work status for some people. People with AIDS are living longer with lower CD4 levels because of prophylaxis, improved supportive care, and treatment. Changes in treatment rather than changes in human behavior account for the decline in AIDS-related deaths. All right. 4.3, special implications for the PTA, acquired immune deficiency syndrome. With advances in treatment, improved care, and longer survival, PTAs can expect to see increasing numbers of people with their people in their practices who may have HIV infections. Maximal effectiveness from physical therapy requires a PTA who is knowledgeable about HIV disease and the unique rehabilitation issues surrounding individuals with HIV and AIDS. It is possible for individuals with HIV infection or AIDS to come to a therapy practice undiagnosed or unwilling to provide their information. Women who have been attacked or are the victims of domestic violence have an increased risk of HIV transmission and do not always report this information. It is important to include questions in the history that consider the possibility of sexual violence and HIV-related disease and correlate this information with the objective evaluation results. For example, anyone with musculoskeletal or neuromuscular symptoms of unknown origin, with or without constitutional symptoms, should be interviewed more specifically about the presence of past or current HIV risk behavior. This may potentially lead to early medical referral, early diagnosis, early appropriate therapy, early treatment choices will also be determined, future therapies because of viral resistance and other factors. Healthcare providers who routinely assess the HIV and sexually transmitted diseases, STDs, risk of their clients can encourage at-risk MSM to be treated annually for HIV, syphilis, gonorrhea, chlamydia, and to accept or seek vaccinations against hepatitis A, B, virus, HBV. Providing a discreet and non-judgmental environment with the assurance of confidentiality with emphasizing the importance of disclosing accurate risk information may help facilitate risk disclosure from young... Lord, sticking everything in that mouth. Okay, where was that? Clients at all stages of HIV infection need psychosocial support to deal with depression, anxiety, and other emotional problems that can develop as the person's condition changes. Screening for depression and anxiety is essential. Referral for further treatment may be indicated. PTAs also may have a role in osteoporosis education, prevention, and screening. Risk factors assessment is advised for anyone with HIV infection. Anyone at high risk for osteopenia or osteoporosis should be referred for a dual X-ray absorptiometry measurement of bone mineral density. Clients should be encouraged to minimize risk for developing osteoporosis with dietary calcium and vitamin D intake, maintaining a normal body mass index, avoiding tobacco, alcohol abuse, and maintaining a long-term weight-bearing exercise program. Prevention of transmission. Healthcare workers may be concerned about potential contact in the workplace with clients who have AIDS. However, the risk of transmission of the virus from client to healthcare worker is exceedingly small. Source of HIV that may pose a risk of transmission through these routes include blood, visible blood fluids, tissues, and other body fluids, including semen, vaginal secretions, cerebrospinal, synovial, pleural, peritoneal, pericardial, amniotic fluid. In addition, any direct cutaneous or mucosal contact without barrier protection with concentrated HIV is a research laboratory or a production facility is considered to be an exposure. Oh my goodness. In the absence of visible blood in saliva, exposure to saliva from person with HIV is not thought to pose a risk for HIV transmission. Exposure to tear, sweat, or non-bodily urine or feces from individuals with virus does not constitute exposure to HIV. Occupational exposure to breast milk does not constitute an exposure unless ingested directly. Healthcare considerations are primarily directed at preventing the transmission of virus when caring for someone with AIDS by avoiding occupational blood exposure. Recommendations for preventing the spread of the virus consist of the use of standard precautions. Specific recommendations for healthcare professional workers with AIDS and HIV positive clients are included in Box 4.2. Everyone with AIDS is immunodeficient, and every precaution must be taken to prevent infection in that person. An individual with HIV does not need a private room unless he or she has a communicable disease that requires respiratory isolation. Hepatitis necessitates standard precaution, but does not isolation. But not isolation. The virus is not transmitted through casual, non-intimate contact or social encounters such as eating in a restaurant. What are you eating? What are you eating? What you got? Lord have mercy. Where was I at? Social encounters such as eating in restaurants or using public transportation or public bathroom facilities, because the virus does not live long or replicate outside the body. There are no documented cases of HIV being transmitted during participation in sports. The very low risk of transmission during sports participation would involve sports with direct body contact in which bleeding might be expected to occur. There is no risk of HIV transmission through sports activities in which bleeding does not occur. Athletes in contact and collision sports are at greater risk for HBV transmission and should be vaccinated against the virus. Post-exposure prophylaxis. HIV post-exposure prophylaxis, PEP, is a form of secondary HIV prevention that may reduce the incidence of HIV infections. The two types of PEP are occupational and non-occupational. Occupational exposure should be considered an urgent medical concern requiring timing post-exposure management. Occupational HIV PEP is an accepted form of therapy for healthcare workers exposed to HIV through their jobs. Healthcare providers caring for persons with occupational acquired HIV. No. Give me that. No. Give me that. Where's I at? Acquired HIV themselves through occupational exposure should contact their state health department and follow guidelines. Well-established U.S. national guidelines for occupational HIV PEP exist. No national guidelines are available for non-occupational HIV PEP after non-consensual sexual intercourse, sexual abuse, and assault. Injection drug use or needle stick or sharp injuries is non-healthcare providers. Healthcare providers with occupational exposure to HIV should receive follow-up counseling, post-exposure testing, medical evaluation, regardless of whether they receive PEP. Follow-up care provided to exposed healthcare providers is important, including follow-up testing, monitoring, and counseling, especially psychologic counseling for those with needle stick exposure or exposure to blood and body fluids. Exposed healthcare providers are advised to use precaution to prevent secondary transmission, especially during the first 6 to 12 weeks post-exposure. Avoid blood or tissue donation, breastfeeding, or pregnancy. Other guidelines for HIV PEP are available. And I'm going to stop right there, page 97. Well, very end of, I guess I'm going to go ahead and read this. HIV rehabilitative therapy. Over the past 20 years, the rehabilitation of the person with HIV or AIDS has changed significantly in the middle of the 1980s. Now I'm going to stop right there, page 97.